Welcome, everybody. I'm glad to see you. I know this year is weird, so I know there's only 4 of you on the call right now, but that is okay. That's why I said we should record this so that others can watch it later. And I've been learning to record basically everything I do now, so I can just transmit it later, and that saves my lecture time. So I recorded my biostats lectures. That's some of you. I don't think I haven't lectured any of you guys yet in biostats because I've recorded them or handed them off. That's the joy of being a director. Now I can hand things off to people. So yeah, I'm glad you guys are here. I'm very excited. This is, I think, the 3rd year we've had an interest group, whereas we didn't have one before. And we're happy to support it. If you guys end up back on campus in a real concerted, seamless way, we will eventually buy lunches for you guys when we have meetings. If I recall, I believe the message was, please no more Chick-fil-A because you get Chick-fil-A all the time. So Alanti's done a good job of getting other things. So Brittany, write that down, no Chick-fil-A. So yeah, and we're here to just help inform you guys on rural health, give you resources towards that path towards healthcare delivery in rural locations. So if you have ideas, questions, please reach out to especially Megan, your point person that can help answer those questions. One thought I had just while we were talking is, I don't even know if we have a sub page on our website for this group. I don't know if that would be helpful. Might be helpful, especially if we start recording these so we can deposit them there and people can watch them later or offline or just whenever, because we're going to have some pretty good guest speakers. I think that'll be interesting. Myself, probably least interesting of all. And I don't know if we have Mark Jordan come in, Megan. Yes, Holly said yes.
Yes, trying to unmute myself. Yes, he's actually already confirmed for September 25th. He stole Holly's thunder for our next speaker, but yeah, he's coming September 25th. He's the follow-up speaker to you.
Okay, great, because he's a really good one that especially if we can record that one, that would be a great one to archive and have accessible year-round, because that's always the question of, well, oh no, what do I do now and how do I pay for stuff? He's the one to go to for that. So I'm going to share my screen, I hope. And I think, Megan, you said you would send them the link for the slides. Yeah, there you go. The file is very large, otherwise we would have emailed it out to you. So I like to do this. I think this is a good way to set the stage of, when we talk about rural and rural health, what is it exactly anyway? And myself and some colleagues wrote a paper for Health Affairs last year that kind of tackles this question in a definitional sense, but also kind of in a philosophical sense. What does it mean to be rural? Some people have said if you have a Target, you're not rural. If you have a Waffle House, you're kind of rural, but if you don't even have a Waffle House, you're definitely rural. My colleague that helped me write this paper said if you can go outside and use the bathroom in your yard without a neighbor seeing, you're rural, which I kind of like that definition, but that's difficult to implement and measure. So, when we talk about rurality, there's a lot of things to consider. So what I like to do, and this should be relatively easy for just a handful of you guys, is to do this poll. And it might be easier if you click the link, or you can do the text thing, and then send a letter. So I haven't done this I think I did this last year, but I don't remember if it worked. So we'll see if it works this time. So basically the next few slides will be you answering the questions, okay? So right here, thinking about the county that you grew up in, okay? What level of rurality do you think it is? Is it urban or is it not urban or rural, in other words? And raise your hand if you have trouble getting on there for whatever reason. I tried this when we did our presentation at the national conference, and didn't realize the free version only limited me to 20 responses. So the 200 people in the room overwhelmed it very quickly. So that did not go well.
It's telling me it's waiting for your presentation to begin.
Oh, no. Well, obviously it's begun.
Here, I'll hit refresh here.
Yeah, it's telling me the same thing to wait for the presentation.
Okay.
Try.
Let me see. Maybe. Try to be fancy and interactive, and it just never works. Let's try one more time. If it's still giving you the error, we'll move on. Let's see.
I'm still getting it.
Yeah, me too.
Well, all right. Well, it was a nice try.
Use the chat?
Yeah, we can use the chat.
Yeah. Since there's not that many of you, we can do that. Or we can do honor system. This is nice because it actually the graphs show up real time as you answer, and it's very cool and fancy and makes me look like I know what I'm doing. So, of course, I can't see the chat, but that's my own problem. So.
See
Anyway.
button down at the bottom that says chat.
Yeah, I can't do it because I'm sharing my screen.
Oh, okay. All right.
Yeah, my box has gone all small and funky, so.
Oh, no. Okay.
It's okay.
There's not that many of us. I'll say, I probably grew up in urban.
Yeah, raise your hand if you were rural by this definition, do you think? Okay. Let's see if I can get. All right, now, different definition. There's 4 levels now: urban, micropolitan, small adjacent rural, or remote isolated rural. So raise your hand if you think you're urban. What about micropolitan? You guys know what that is, right? No, probably not. Small adjacent rural? Maybe, Megan? You better know by now, Megan. Remote isolated rural? Anybody? I'm small adjacent, just FYI, according to that. All right, now which one of these do you think you are? You are urban 2,500 to 19,999, or completely rural, not adjacent to a metro area? I'll give you 2 seconds to decide. It's more dramatic when the poll numbers are coming in and people are scrambling and have no idea. Or maybe by this definition. Which level of rurality are you by this definition? So, it's a little like it's not as cool without the graphs, but I think, well, then there's the urban flows and the census definition as well here when you talk about commuting flows. So the bottom line, there's a ton of different definitions. Right now, the last time we counted, there were about 76 different rural definitions in use by different groups around the country. And it's kind of hard to know if you're rural. This is a really good website for federal purposes. You can actually go in there and type in an address. So if you wanted to go and type in your home address or where you live now or the village in Alaska you worked in, and it will tell you what level of rurality the feds consider you. What's interesting about this is you'll notice that, if you play around with it, there are some locations that are considered rural for one program, but not for others. You might be rural according to Medicare, but not according to census, or not according to HRSA. And it causes a lot of problems for healthcare organizations and people who are trying to get a grant or get differential reimbursement. You can get loan programs and different programs if you're in a rural area, but it just kind of depends if you're rural or not. So it's a fun one to play with. It's kind of disheartening some parts of our state, for example, that don't qualify as rural. But if you went there, you'd be like, I haven't seen anything more rural than this before. So I wanted to give you some visuals here. I'm not going to test you on this, obviously, but this gives you an idea of some of the different definitions. This is a census definition of more about urban areas. And one of our pet peeves is that rurality tends to be defined as not urban. It's not this, or it doesn't have people, or it doesn't have that, instead of actually defining it by what it is. So any of the dots or the purple areas are considered urban clusters or urbanized areas, okay? And if you look at it, it kind of makes sense, depending on where you've traveled and whatnot. There's only 2 little dots in Alaska, for example, because they have some city cores like a Fairbanks or an Anchorage, and then nothing else outside of that. South Carolina, you can see the pockets. You got Columbia, Augusta, Charleston, Greenville area, and then Florence, Myrtle Beach. You got a couple other little urbanized area pockets in there as well. Here's the close-up of that, where you have larger areas in red, and then the smaller and these are kind of like your large towns, maybe not quite city-sized, but larger areas throughout the state. There's a little cluster. If you look at where Columbia is right there, that big red dot in the middle, just north of that, there's this little blue blurb. That's an urban cluster. That's Winsboro, South Carolina. And we'll talk about that a little bit more later. So anything not in these areas, we would consider rural according to the census definition. Here's another definition. This is the Office of Management and Budget, federal office, where they've defined rural areas as county level type things, which that has a lot of problems. If we go back to this slide, you can see there are not very many counties that are fully urban, not here. If you talk about New York, that kind of corridor, maybe where Baltimore is, you might have entire counties that are urban. South Carolina, definitely not. There are parts of Richland County, for example, that are more than 30 minutes away from an obstetrician, just because of rivers and natural things like that. So, I really don't like using full county definitions because it masks a lot of the disparities in access and population densities. So you can see here this overlap between the clusters and the urbanized areas, those red and blue clusters. And then here, the non-colored counties are the ones that are considered non-metropolitan according to that federal definition. You can see there's a lot more that's considered metropolitan, or in this case, a metropolitan statistical area, that really you wouldn't necessarily consider urban. But it has to do with, like, if you are in Winsboro, you can get to Columbia in 35 minutes. Therefore, they don't really consider you all that rural, even though there's really not a whole lot else there. And this is problematic for a lot of reasons that you can probably surmise, because Winsboro is not eligible for a lot of rural programs, for example. This is a little different. These are also county level rural urban continuum codes. They're a lot more refined in the sense that there are 6 different levels of non-urban, non-metro areas, kind of broken out a little bit evenly, but you can see kind of the darker green, the more rural it is, the more isolated it is. And if you know the US, none of this is really surprising. You got that swath of dark green in the middle of the country. The lighter colors are the more urban areas. This is also not surprising, but it is also, again, county based. So it kind of masks all those lower level geographical differences as well. These are urban influence codes, which is another level of refinement. There's 12 levels to this, and it just further highlights those key differences. That stark line, that frontier line, really lights up in the middle of the U.S. Here, what I think is interesting, if you look at Kentucky, West Virginia, even down to Virginia, North Carolina, you see Appalachia kind of light up there as really isolated rural. You can see parts of the black stroke belt going through South Carolina, Georgia, Alabama, where you have high rates of stroke and heart disease through that belt buckle of the South right there. So there's some interesting things that light up here, but again, it's county level. A lot of things are really kind of masked if you look at it this way. And again, here's another map showing, if you look at those codes you got the clusters, but then according to this, there's a few more areas that are non-metropolitan because it's a more refined measure. But still, there's a lot of red counties here that I would consider rural that these other definitions don't. So it really doesn't serve as really well, to be honest with you. I always like to look at more refined. This is zip code level. And you can see there's a lot more detail here, but there's still, you know, if you're looking at root codes, I didn't show you that map, but again, large problem is a lot of red here. Even when we broke it down to a smaller level, the way the definition's operationalized, it still considers a lot of it as an urban area where, you know, if you've traveled our state, you know there's a lot more around here that is just should be considered rural, and it's not. Okay. So for example, these are pictures from Winsboro, South Carolina. Okay. You got natural open spaces, the downtown area here, it's like stepping back into the 50s. Most of the shops are closed. The Walmart closed because it couldn't be sustained, which is hardly ever happens. So this is an underserved area. I think there's one dentist's office in the county. Primary care services are underserved, high rates of poverty. All these issues that you traditionally see with rural areas are really highlighted in Winsboro. But because of the commuting patterns and the fact that it's not that far from Interstate 77, it's considered part of the Columbia area. So from the federal perspective, they're not eligible for certain grants, loan repayments, things like that to help them move forward. Other definitions that I would use, like the census definition or some other codes, I would look at this and say, yes, this is absolutely rural. And our center actually works in Winsboro to help prop up their services because it's rural. It's a fun place to visit if you ever get a chance. I think, Alyssa, you went there with our class, right?
Yeah, I did.
Yeah. So
the emergency department up there.
Right. So the class I taught last fall, we made a visit to their freestanding emergency department because their hospital closed. So they don't have a hospital in their county, but they do have a freestanding emergency department that was built by Providence. And now I'm not sure who owns it because Providence's ownership is interesting. So a lot has changed in a year. So this is what I also find this interesting. These are all pictures of urban areas across the U.S. Okay, the Grand Canyon is considered urban, even though it's clearly not. It's a giant canyon because it's in the same county as Flagstaff. It's a very large county, especially when you go out west. Several counties can get very, very large. And Flagstaff is in the very southern part of that county, big urban center. So that county, according to the federal definitions, even though Grand Canyon is probably, I don't know if anybody's driven it, probably 5 hours or so drive from there, is still considered an urban area, so not eligible.
Yeah, it's several hours. I have family out there, and we did Flagstaff to the Grand Canyon. It was a drive. Yeah.
It's a trip, yeah. This Eli, this is in Minnesota, Dr. Casamanal, who does a lot of work with maternal mortality work in rural areas. Population 3,000 people, far-flung areas of Minnesota, very poor access to obstetrics, very high maternal morbidity rate and mortality rate. But since it's a very long, skinny county, it's not eligible for any services because it's considered an urban area. So there's all these kinds of problems that we're trying to deal with. So when we talk about rurality, we tend to kind of hold our nose and say, yes, this is what the feds consider rural. Us as a center, we consider it very differently and more realistically, I guess you could say. I want to give you a couple examples of some South Carolina counties. This is Lawrence County. It is considered an urban county, according to several definitions, but the majority of the zip codes are actually rural. So the only part of this county that is an urban zip code are the ones in color there. And this is kind of up 26. If you're going from Columbia to Greenville, you'll see signs for Clinton. There's really not a whole lot out there. It's a very sparse population, a lot of countryside, some agricultural things, but then there's some there is an urban kind of core there, as you can see, those zip codes that light up there. But like I said, this whole entire area is considered urban because of the various definitions. Whereas Chesterfield County, which is interesting, and this tells you a lot about the definition problems we have there as well, the county is considered not urban or rural, but a majority of the zip codes are considered urban, which doesn't, you wouldn't think it would go that way as well, but it does. Mostly because they do have some towns in here that have enough people within the certain area that it kind of pushes it over the edge to an urban area. But because of the definitions that are used, Chesterfield County is eligible for a lot of federal programs, whereas Lawrence County is not. So it's an interesting mix of issues that we have when we talk about these things. People sometimes ask, how many rural counties do we have in South Carolina? And I'm like, I tend to refuse to answer because of these kinds of issues right here. Okay. So when we talk about rural South Carolina, I always kind of try to remember that we're talking about people that live there and not, fields and valleys. So who are the residents in rural South Carolina? And again, you kind of have to hold your nose and pick a definition for this. These are generalities based on kind of floating averages across all of them. So think about trends more so than the specific numbers, but generally speaking, it's slightly more female than urban areas. Definitely older, which is common across all of rural America. Younger folks tend to leave to go to colleges or to jobs, leaving behind older folks. Tends to be more non-white, so it's a much higher African-American population. And some Hispanic, it varies county to county. Some are much higher, some are much lower. Fewer Asian Americans. The employment rates are lower. Part of that is due to the age range, but part of it's just because there's fewer educational opportunities as well. There's higher that are not in the labor force at all, working from home or stay-at-home moms or whatnot. Typically have lower insurance coverage as well. Again, since this country's ties insurance to employment in so many different ways. If you do work in a rural area, you tend to not work for a large enough company where they offer insurance, or you're self-employed. You think agriculture or tourism or any of the other industries that are common in our rural areas. So there tends to be lower insurance coverage. Those that do have it have they're much more likely to be Medicare or Medicaid than to have private insurance, which causes some downstream effects of lower reimbursement. It's harder to get providers there because the reimbursement's lower, those kinds of issues. Okay. The issues we have here are not unique. And there's a typo, lovely. Brittany, you're supposed to fix those for me without me telling you. So, dirty secret, I've been a PhD for 15 years and my spelling has gotten worse every single year. I cannot spell to save my life. But anyway, so there are fewer resources definitely in these areas, which is not surprising. There's lower populations, but even when you look at it, subset by 1,000 population, there's still fewer resources of pretty much all sorts. Here's some maps that we've done. This is a travel map for 30-minute travel times. Okay, so you can see the dark red are the areas that are more than 30 minutes from a primary care doc. Okay, the mid-level red is kind of in between, and the pink is 0 to 10 minutes. So there are huge parts of our state that have significant travel time just to get to a primary care physician of any kind. Think about where we are. Gosh, where I live, there's probably 20 primary care docs within a 10-minute drive of where I am. What's interesting, if we dial down to, where are we? So there's the lake. There are portions of Richland County that are actually underserved, where you do have significant travel times to get providers because they tend to locate, I live in Irmo. people like to live out here or to practice out here because it's a higher insured population, higher privately insured population. So, you know, they can get better reimbursement than if you work downtown. There tends to be higher Medicaid and Medicare reimbursements, which tends to be lower reimbursements. Here's a similar map for obstetrics. You can see entire parts of the state that are much more than 30 minutes. You look at the southwest corner there, where you have a huge swath of not having any obstetrical care at all. So those folks are 45 to 60 minutes away from an obstetrician. So, you know, we have obvious gaps even in our state. We're a smallish state. You know, if we did similar maps for counties and states out west, you would see 2 to 4 hour travel times for obstetrics, 1+ hours for primary care. So there are significant issues even here where we're more densely populated in a smaller state. Here's the location of our obstetricians. You can see anywhere there's a white zip code, there is not an obstetrician right now. So that's, you know, they're kind of concentrated. They're not really located where everybody is. So pregnant mothers have to travel to get just care, you know. And you think about those of you that have been pregnant, maybe just Megan, I don't know. I have not, my wife has, obviously, but you know, that's not a comfortable thing. You know, if you're between that third trimester, you're uncomfortable. If it's your first one, you're going to be anxious because you don't know what is what, every little feeling. You want to go for a checkup, and driving 45 minutes to an hour just for a checkup, to, you know, that's a significant burden. And as a result, you have women who might ignore things that they might need to get checked out, or might receive care too late to really intervene and have better outcomes. So it's a significant problem that we're actively trying to work on for the state. And here's a similar map for psychiatry as well. And you can see there's even fewer psychiatric resources across the state. Now, this is just psych. This isn't our entire mental health workforce. You know, talking about MSWs or other types of social or psychological behavioral health interventionists. But, you know, I think it still paints the picture, and mental health has traditionally lagged behind. We've not given it the attention it deserves. And hopefully that will be changing. One of the silver linings of this COVID mess might be a greater attention to mental health services, especially opening up telehealth for that kind of thing would be extremely helpful. And then finally, so if you have the slides, you can link to this. If not, I don't know if Megan, if you have that link or not, you could probably find it. But this is a dashboard we're working on. It's still in the beta version. So you can go around and play with it. That would be actually excellent for you guys. One thing that we're doing, and actually, let me see if I can share a different window. No, that's not what I want to do. All right, let me do this. Let me stop sharing and then share a different window with you. Ah. Aha. There we go. You guys see that now? Okay. So we got different tabs up here. We have a data sheet here where you can choose a county and any or all zip codes in that county, and it gives you a whole mess of information about that county and their zip codes in there. One thing that we're working on that would probably be of interest of you all is this placement score, this PCP placement score, where the darker the color, the greater we've calculated the need for primary care providers in the state. And it's almost a mirror image of what we consider our rural places. Pretty much all of our rural places need PCPs in some form or another. And what we're doing, we do have a loan forgiveness program that they'll probably talk to you about later, probably in conjunction with Mark Jordan's presentation, where it's for MDs, nurse practitioners, and PAs. And upon graduation, you work in a rural, needy area, and we forgive portions of your loan. And so we're using this to kind of identify where good places to go would be. So you can actually click on a place here. It gives you the zip code and the placement score. And the closer it is to 100, the greater the need is. So we're working on these kinds of things to try to be actual interactive tools for information for providers. We have a similar thing for obstetrics care. But then we also have things, if you want to go into obstetrics, if you want to be a family medicine doc and deliver babies, you can also look at birth rates. Okay, maybe you want to overlay, okay, there's a high need area here, and also there's a higher birth rate here. So that might be a really good place for to put an obstetrician, because there's some demand there and those kinds of things. We have travel times. And then, we've got a bunch of other things in here. For example, inpatient visit rates. If you want to look at that kind of demand, there's a broad, much higher inpatient visit rates over here in the PD Florence corridor between Myrtle Beach there. So what's going on there? It's an interesting thing. So, if you want to look at the percent uninsured by zip code, you can see the variation here. This needs to be updated. Obviously, this is not updated with today's reality. Not even sure we know what today's reality is, to be honest with you. I've read an article today that we're not really sure yet. But anyway, this is just an interesting thing to play around with. One thing you could do too is if you looked at it, I'm open to feedback on, man, I'd really love to see this data point. Man, it'd be cool to look at it this way or that way or whatever. Especially like the placement type stuff. Here's income, median income. And then type 2 diabetes, which I'm surprised the whole state doesn't light up. But, you can see, there's a lot of overlap here, because one thing that we're trying to measure with need, it's traditionally just been, how many providers per 1,000 are there in a county, which doesn't really tell you a whole lot, because you might need more providers per 1,000 if you've got a lot of folks with diabetes in that area. And that's what we're trying to get to here. Oh, there's more diabetics here. There's more women of childbearing age. There's a high birth rate here. That area really needs a good obstetrician, for example. And they might need a couple more than an area with a lower birth rate and lower diabetes rate would. Okay. So I think you should be able to get that link at some point. All right. So all that being said, I think that's it. I think that's all I was talking about.
And I did get the links in the chat box.
Okay. Yeah, so you can take a look at those slides and go through them, but that's kind of a quick overview of, rural South Carolina, especially. You might be more confused now than you were before, and that's okay. It is confusing, but I think it's okay to be confused because, like I've kind of built a career out of studying rural. And here I am in year 20, basically, and I'm writing articles on, well, what is rural? We don't even know what it is. So we need to write an article about that and present on it. And it generates all this discussion. That presentation we did at the national conference, the debate afterwards was more interesting, I think, than the presentation because people were asking good questions. And we were like, yeah, we don't know. That's a great question. So South Carolina is a little bit easier. Like I said, I'd like to use zip code area type definitions. I think we're using the root definitions that are zip code level and a little bit more refined or precise. But for other things, we'll use other definitions. It kind of depends. So with that, I'll be done and let you guys ask me any questions or comments or anything of the sort. Happy to entertain.
Since Dr. Bennett can't see the chat, if you want to ask any questions, you can just go ahead and unmute your mic.
I can see it now as well, but yes.
Oh, all right. Whenever.
Now that I stopped sharing and everything came back, so. And I will give a quick plug that we do have a podcast about rural South Carolina. And our very first episode was about this whole question of what is rural as well. So go subscribe and download to get our numbers up.
I had a question, and
Yes.
sorry, I just jumped in, so we might have answered this, but I was
Oh,
just
you're good.
curious if Dr. Bennett and Dr. Weiss, if you are from rural areas, and if not, or if so, like kind of how you got interested in rural health.
Yeah, so I came from, and again, depending on what definition you use, I would consider it rural Virginia, Southwest Virginia, a suburb of Blacksburg, Virginia. So Virginia Tech. I did my undergrad there. Both my parents worked there. But we were surrounded by cow fields, and I think there were 500 people in my high school, which covered the county. So, I would consider it rural area, probably, small adjacent rural, if you think back to those definitions. We were right next to Roanoke County and Roanoke City, which is about the size of Columbia, but it was a 45-minute drive. But a well-resourced rural area. We had a hospital, we had doctors, with a university there. If you took it's a very, very analogous to a Clemson, actually, is a really good way to look at it. Proximity to Greenville, college town, all those kinds of things. Interestingly, I took a similar path to Dr. Weiss as far as, my undergrad and grad work was exercise science, health, nutrition. My master's was kind of a combo of that and leadership and management, which is kind of where I got the health services research bug. And then I came to Carolina, actually got my doctorate in public health research. And that's where I got plugged into the rural health aspect. I wasn't really coming with rural in mind, but I was coming in the mind of the health system sucks and people are underserved and how do we fix it? And they had just stood up a rural health research center, and I got attached to that as a grad student and fell in love with it. So I've been doing this since 2001, which is really daunting to say because that's a very long time ago. Actually moved to, today being 9/11, we moved to Columbia in August of 2001. So 9/11 happened while I was in class, basically. I remember driving to class, heard on the radio that a plane hit. I didn't know. I thought it was just a small private plane. I called my wife to watch the news, and I went to class for 3 hours. And this was kind of pre-cell phone, all that kind of good stuff. And I came out and I was like, wait, what happened? So that was an interesting day. Kind of gives you a glimpse into what my context, I guess. But yeah, I think rural is a fascinating thing to look at because I think it highlights a lot of the issues with our healthcare system in a lot of ways. Other countries do a really good job of not really caring if it pays for itself because it's a service and it's something that the population needs. And there's, rural is a vital part of our country. People tend to think of farming, but it's so much more than farming. There's just so much that, our country depends upon for rural. And, looking at our history, we are a majority urban country, but that's been less than 100 years than that's been the case. So thinking about just the history of our country, the West and all of that, we're driven by our rural areas. And, it's unconscionable that we're kind of leaving them behind in so many ways. So we're working to fix that. So that's a very long-winded answer to a good question. Sorry.
No, that is a excellent question. So I grew up outside Boston, as I mentioned, Framingham, which is along the Boston Marathon route. So that most definitely was not rural. Mile 6 at the train station for that, and then moved to Malden, South Carolina, right before my freshman year in high school, which I still wouldn't call rural. And went to Furman, still, urban, suburban. We thought we went to rural areas, but I just didn't know for that. And I'd say my first real experience with that was when I joined the Peace Corps. And so it wasn't American rural, it was rural in Malawi. And I actually lived about 45 minutes by private car mostly off one of the main highways from the capital, but the catchment area where we work, it'd be hours and hours in the back of a pickup truck for that. So really seeing more of that international health side. And with that, but I mention it because that's where I really discovered and I fell in love with public health. I had taken a elective my senior year in college. It was like, oh, this stuff's cool. Hey, I can get experience and travel in the Peace Corps and do good, save the world, learn, and, everything all at the same time. Learned so much from that. But there was a couple of experiences that really brought home rural for me. One was within those first few months of coming home to South Carolina, I decided to come to the Arnold School for my MPH for a variety of reasons. And I was driving through South Carolina and maybe on the way to the beach, I forget. I think my now husband was with me. He came back from Peace Corps and came to South Carolina. But we were driving along the road and we were looking out the window and it looked exactly like Malawi. I mean, the landscape, the red clay, central Malawi, the dilapidation of some of the buildings, it just was, I had gone halfway across the world to try to go help people and discovered that it was all here in my backyard. It was right here. So that was very formative for that. And I've never forgotten that moment. I mean, the smells were the same and it was very surreal. It was almost like a flashback. Went on, got my master's, worked at DHEC around the state, and then got into some nonprofit work, working with state health policy and stuff. So not really working specifically in rural. Some experiences. My husband, as I said, we met in Malawi, but he's from very rural Iowa, from a dairy farm. When I wouldn't even say very rural because they're still about an hour away from Dubuque, 30 minutes to an hour away from Dubuque. Then the first time we drove there, the first time I'd really, not just flown west of the Mississippi, but been west of the Mississippi right there. We were driving through Southern Illinois and I was freaking out because the gas gauge was getting close to empty and I couldn't see any gas stations anywhere. And he kept telling me we could get off the interstate and get some gas. But I'm like, oh, no, because I was used to seeing all the exits and everything else. And this follows right after we had driven between Columbia and Greenville, where my parents were. And he just kept talking about how crowded it was. Now, this was over 20 years ago. So think even fewer exits and fewer buildings. And I'm like, what are you talking about? There's nothing in between. Then I learned when we drove through Southern Illinois. But anyway, continued on my career in South Carolina. And the more I did work and running into people like Kevin and learning about it, and a good friend of mine, Melinda Merrill, who's done a lot of work in South Carolina, just learned more and more and more about the importance and realized that some of the work I was doing where I thought I was helping rural or considering rural really wasn't doing as much as I thought because I didn't truly understand it. So I was learning more and more and more. And then about a little over 6 months ago, had the opportunity to really jump in full bore and really be able to learn and be a part of that. So I guess you could say I'm a latecomer. It's not something I was born into, but I think it's very meaningful because I have found my way here. So that was my long-winded answer. And I was in grad school with a master's on 9/11 and driving to my GA and heard about a plane hitting. Thought it was a small private plane too. Was at DHEC, heard about a second plane and thinking, that's probably not a coincidence. And then the small TV in the break room at DHEC showed the towers and is like, that wasn't a small plane. And yeah, the realizations.
So I had a question. So just speaking of everybody's background, so I've always heard that physicians who grew up in rural areas were more likely to practice in rural areas. So is that something that's true?
Yes. So yes-ish, but it's not as strong a connection as people think it is, or not as strong as it has been in the past. I think one of the more unfortunate trends has been due to the rising cost of the education. And when you're graduating with $200,000 to $300,000 in debt, it's really hard to go back to a rural area and make half what you could in an urban area. Even with loan repayment programs, which are wonderful, and Mark Jordan will talk about those, and you all should do every single one of those. It's still hard, and then you get mixed into that families and school systems and amenities and all those kinds of things. It's hard. So there are a significant number of people who grew up in a rural area, find their way to med school, get through residency, and go back and serve. And rural would be much worse off without them. But it's hard. There's been a push for rural training tracks and rural residencies. We are actually doing that ourselves in a lot of ways. We have a residency in Sumter. We support a residency in McLeod, Florence area, which is not really rural, but rural-ish. The thought being, if you train, especially residency in a rural area, you'll realize, oh, no, this is feasible. I can do this, and people will relocate there. And that has borne out some as well, but even those don't have a 100% track record. Now, philosophically, this COVID thing has changed a lot. I've those that know me well would not be surprised. Megan, I think you've actually seen it. My Where is Rural Going Marshall Plan / manifesto. It's I hesitate to say manifesto, but it's a little ranty at times. But I think with opening up telehealth, for example, so COVID, they loosened a ton of the restrictions on that. So now it's actually workable, easy, and reimbursable. That makes it accessible. So that's one thing that if you're a family medicine doc working in a rural area, that's one problem that you have, is that lack of collegiality, lack of access to providers to refer your patients to consult with. They need a cardiology consult. They have to drive an hour to Columbia to do it. Now they can sit in your office and do that consult one-on-one with you in the room or not. Same thing with mental health services, things like that. If we can keep that going, that would be a huge boon to getting more rural providers out there. I hesitate to say, because it's so incredibly bumpy. Megan and I both have kids in school systems right now, but this grand experiment by force of online education, I think, could also be beneficial, where a lot of rural districts don't have the resources to offer those upper level classes. My kid's a freshman at a high school, and he's taking intro to, it's an intro to engineering principles class, which I'm like, where the heck was that when I was in college, But he's not going to be able to do that if he lives in Kershaw County. They just can't offer that. But if he lives in Kershaw County and he can log in during school time to that intro to engineering class in Irmo, that opens up a lot of doors for parents to be like, school systems are all kind of the same because they all connect. Are we going to get there? I have no idea. Is South Carolina going to get there? We'll get there after everybody else, like everything else. But not to discourage you all. But, I think there's a lot of good things that could change because of this that would open up a lot of doors for you all, because you guys are all first or second years, right? So you all have 6 to 7 to 8 years before you're actually practicing, thinking post residency. Gosh, 8 years ago, 2012, what did we not have that we have now? Those kinds of things. So yeah, so I don't know if that answered your question or not. It led me to a rant. I'm sorry. But.
Thank you.
So I was wondering, when we think rural health, we obviously think family medicine, some OB-GYN, psych, but are there any specialties that are needed or even possible within a rural setting that kind of aren't immediately what we think of?
Yeah, so obviously family medicine is a big one, because, cradle to grave is kind of their mantra. Family medicine is interesting because a lot of family medicine graduates don't deliver anymore because of the malpractice and the training and things like that. So we need to improve that. Internal medicine are increasingly in rural areas because they could work in a primary care setting. OB, obviously peds would be a big one. It's a little bit more difficult if there's just not a large child population. You need a certain panel size to maintain your practice. But some folks are setting up like hybrids where they spend 2 days a week in the rural location and 3 days in the suburbs, and they live somewhere kind of in between. One specialty that's interesting, we're trying to get general surgery classified as a primary care specialty for rural places, because that's been a huge need for the rural hospitals and even freestanding EDs that are out there. As far as, just we don't need an orthopedic surgeon, we don't need a cardiac surgeon, we just need that general surgeon to be the boots on the ground, do a lot of the minor things, do some triage work before we ship them off. So, trauma cases might need to stabilize it before you can transport safely. What was the other thing? So psych is one. A lot of the ancillary type professions are really, really needed. Pharmacy, social work, nursing is a problem everywhere. Anesthesiology is probably one that's where the rise of nurse anesthesiologists has been extremely helpful as an extension of that. I was thinking of something else. General surgery providers, physicians. Shoot, it's too late on a Friday. What was I thinking? I was going to say something thoughtful, but it's gone. So there are a few others like that are coming out that you could establish a good practice, and or some sort of hybrid practice where you might go to the community and work a couple times a week to do those kinds of things.
Awesome, thanks.
I was curious, do you see any downfall to physicians or providers living in somewhere more urban like Columbia and then commuting to work, 40 minutes to a rural setting? If, I definitely am interested, serving those people, but I still can't wrap my head around living in a super rural place. Is there any downfall to that?
Yeah.
Or is your opinion on that?
Yeah, you just opened up the box of debate that people like to engage in. There is a philosophy that to be a really good primary care doc, you need to live in the community. And some communities really, really, really expect that. We take a more practical approach, to be honest, knowing that some people just don't want to live in a rural area. So what's the harm in them living 35, 40 minutes away and driving in to serve that? You can still get to know people, you can still be involved, but you're going to live somewhere else. I don't think the quality of your care is not going to suffer because of that. I think the trade-offs will be, if you don't live there, you don't know the community as well. I think that is certainly true. You may not know the resources available. You may not know attitudes, those kinds of intangibles that you might need to be aware of. Some stigmas might be around, that kind of thing. But that's where you can really rely on your staff, because probably the staff of that practice are going to live there. The nursing staff, the ancillary staff, the front desk staff. Hopefully, if, they might even be from there. So they might be able to, if you listen to them and have a real team-based approach, I think you could cover a lot of those intangibles. But yeah, that's been a thing where, especially with like these loan repayment or other incentive programs where, our goal is to get a provider there and serve them. I don't care where they live. I don't care if they only stay there for 5 years. Because some communities don't want to even participate in that because they say, hey, we don't want them there for 5 years and then leave. We want someone to stay there for 30 years and make a career out of it. And we're like, yeah, that would be awesome, but that's lightning in a bottle. You're not going to find that. So just, if you turn it over every 5 years, at least you've got somebody, and then you focus on your staff, your office manager, your head of nursing as your continuity of care.
Well, and then also you might have someone come in who does want to stay, but very few people are going to make a 30-year commitment at that stage, if that's the expectation.
Yeah.
Once you put down roots and you live there and stuff, it's a possibility, but.
Right. Yeah. So that model that you described is very common now. There are trade-offs to be aware of, but it's very common.
Awesome. Thank you.
Mm-hmm. I will put in a plug for all of you and spread that to other students. There is the National Rural Health Association. I've been an active member of them for many, many years. I'm kind of quasi student group liaison with them. They have a robust student group that probably 300 to 600 people, depending on graduation rates and stuff. Primarily medical students are part of that student group. At the annual conference, they actually have a half day that's just student sessions. And that's a really good resource to connect to. I think to join, it's like $25-$35 a year. So it's really not a whole lot.
Student memberships are $15.
15. There you go.
Yeah, I just put the link up.
Yay. I'll pat myself on the back. I actually started that back in 2001. We didn't have one before then. And I went as a PhD student and I was like, we need a student group. And they were like, okay. And so here it is. It's still going. So that's kind of fun to see that. But that's a great way to connect with other interested folks like yourself across the country. The chat boards are great. I think they have like a town hall, a virtual town hall once a month. They have a Facebook group. And it's a great way to learn, a great way to network. The conferences are great. You'll learn a ton. They are planning on doing the annual conference in May next year in New Orleans, which is accessible and fun. Depending on you guys' schedule, I know med school schedules are kind of tough that time of year. But that's a great resource. Those questions, some of these questions you're asking, a lot of those folks have those same questions. There's a medical educators group that routinely answers those questions and walks all of you guys through that. And there's just a lot available through that system. So I'd encourage you to get in touch with that. And at $15 a year, that's a no-brainer.
We could figure out South Carolina student cohort over there. That'd be fun.
Yeah, and so that's something that we're trying to figure out how to do at the national level is how do we support student chapters and how do we have like an actual system for that? And so we're actually working on that. What's fun is that as you know, the student group elects officers, so you could be a president of a national group, and those officers serve on the board of trustees for the national group. So there's some good leadership opportunities there. Get you some access to some really good folks, and you know, unlike other groups, we listen to our students because they're like, hey, what if you supported student chapters? We're like, that's actually a great idea. Let's work on that. So we're working on a toolkit of like how do you start one? What kinds of things do you do? That kind of thing. So. What else? Anything else? Well, feel free to reach out to me at any time. You know, I know Dr. Weiss is your mentor advisor. You can obviously reach out to her at any time. Don't be shy to talk to us. We're here as, especially Megan, at your point. You guys are interested in rural health. We're here to foster that. So if you have questions, I mean, just random questions, email us. We don't care. Okay, we're not going to give you our phone numbers, but email us. She gave you our Twitter and our Facebook. You can do that. You can find me on Twitter if you like. It's unofficial, so I didn't post it.
Yeah, I'm on Twitter too.
Yeah, we're both on Twitter, and we sometimes
professional.
Yeah, professional. I have a disclaimer in my bio for just that. But yeah, reach out to us with anything. If any of the other folks who aren't on the call, if they have questions, if they're like, hey, you know, that kind of thing, you guys want to set up a field trip somewhere, we can give you great ideas and great connections. There's some really cool stuff that you could do if you would like. But yeah, don't be shy. We're here to encourage your journey. And, you know, when you go into 3rd and 4th year in clinicals, don't forget about us. If you have questions there, reach out to us. You know, just because you're, you know, at a different phase doesn't mean we're not still around as a resource. So,
right. Well, thank you.
Alytha's going to see me for years, I think.
All right. Well, thank you so much, Dr. Bennett. And Dr. Weiss included a lot of links in the group chat, so we can compile an email and send that out to chat, so everyone has it in one place. But thank you so much.
No problem. My pleasure.